Welcome to UFA Roll Call Podcast. This is a special episode for Firefighter Health and Safety Week. We have special guest Dr. Jeremy Biggs, Captain Mike Greensides, Cal Allegro Ricotta, and Lane Hilton. Captain Lane Hilton.
What's up?
What's up? All right. So let's talk about some firefighter health and safety issues. What's the first bullet point we're going to be covering?
Well, the first thing I'd like just to, again, tell Dr. Biggs, thank you for being here and being willing to do this. This is a unique opportunity, and we value your opinions and your judgment, and especially the partnership we have with the University of Utah. Obviously, we think that you guys bring a much higher grader of professionalism to this, to our firefighter physicals and our past provider. And this today's podcast is to try to identify little components of that NFPA 1582, understand them a little better, and especially some of the changes that have happened recently, and why certain follow-up tests are necessary. So we'll turn the time over to you.
All right.
Thanks, Doc.
Sounds good. And yeah, we do enjoy working with you guys. You guys are definitely kind of a cut above some of the other firefighters that we're working with. And so we appreciate your guys' focus on health and safety. So just, kind of, there's some bullet points. We'll go over those, of course, and then anything else that you guys want to talk about. Occupational medicine at the University of Utah, we are a group of physicians that are board certified in occupational medicine, which is a specialty under the American Board of Preventive Medicine. And, obviously the two main clinic locations we have right now are going to be Redwood and South Jordan, in the Daybreak Clinic.
Can you explain that specialty a little bit? What is that?
Yeah. So, some background. So occupational medicine is, like I said, it is a specialty, but it's kind of a broad-based specialty. Really what we do is we train and are devoted to prevention, a big component of prevention, which is mainly what we do with you guys. Of course, we do take care of injuries and stuff as well, but we just focus on prevention and health and safety of workers in different industries.
Okay.
So within the specialty, we will have clinical operations like we have here at the University of Utah, where we see you guys. And then we sit on boards of corporations a lot and work with health and safety professionals, IH guys, ergonomics, and so forth to try to prevent things from occurring.
That'd be industrial hygienists.
Yes, industrial hygienists.
IH.
Right on.
Yes. And then, of course, there's a big regulatory environment. NFPA kind of fits that, right? They have a standard that we follow. And, of course, there's OSHA standards and other standards that we have to kind of help make sure that people are following. And
So is NFPA your main guideline that you're working off for us?
it is, because it's the most comprehensive guideline for firefighters.
All right. Right on.
Not everything's covered with NFPA, so sometimes we do have to use either just clinical knowledge or other standards, but 99% of what we recommend and do is based off of what NFPA says.
Okay. So Mike, for you, what is NFPA 1582? What exactly is that?
Well, I think the doc has that covered, don't you, Doc?
Mm-hmm.
Yeah. So we'll just allow him to get into
All
that
right,
discussion.
Right on.
Yeah. So, so 1582 is basically, I'm going to pull up the slide so I can make sure it's the part that has medical clearance. So it dictates health conditions that can or cannot be accommodated with a firefighter. So there's two main categories of health conditions that the NFPA states. Category A, which says if you have these conditions, then there are some limitations that you may have to have. Doesn't mean you can't be a firefighter. It just means that there may be some accommodations, something else you have to do or something in order to make sure you do your job safely.
Like hearing, for example.
Like hearings,
That's weird that I would bring that one up.
So yeah, certain levels. So there's also, for hearing, for instance, there's a category A and category B level. Category B is we get a little bit more clinical judgment on those. So they'll have a range and they'll say, okay, category A, if you're completely deaf, that's going to be a category A, right? You can't do your job safely if you're completely deaf, can't hear anything. But if you have, bad hearing in certain areas, then depending on the frequency and the level, then maybe you need to get a hearing aid or something else. So it becomes a category B, but there's some work we can do, some additional things we can take care of in order to make sure you're fit for duty.
Right on.
Does that make sense?
Yep.
Okay.
And Dr. Biggs, that goes as well with medications that are taken.
Go right into the mic there. Ask your question one more time.
And the categories are for medications taken as well by individuals.
Yes. So almost everything we ask you about in that really long history form, if you pay close attention, you'll see these little numbers over each category. So there'll be a group of questions and they'll be like, 9.1, 0.2, 0.3 or whatever. That's actually referring to the section of the NFPA 1582 that's covered by that.
Oh, okay.
And each of those categories has category A conditions and category B conditions. So medications are going to be that way, cardiovascular, vision, mental health, all that kind of stuff, diabetes.
So is A an automatic out, or
It can be an automatic out, or it can be an automatic limitation. So not a complete out, but saying there's certain job limitations that may be affected by this condition. And in the 1582, there's a list of essential job tasks of a firefighter. I think it's 1 through, I want to say 13.
Yeah, something in the tenants of some kind.
Yeah. And it goes through each one. And if someone hits a category A, they'll say, if it's category A, then you need to look at 4, 5, 7, 9, 12, 13 and make sure that they can, if there's any limitations in here, you have to let the fire department know.
okay?
Then ultimately it's up to the fire department to say, yeah, we can do this. This is fine. We feel safe with this or not. I mean, we don't technically say you can't be a firefighter. We just say, based off the standard, here's your findings, here's your health concerns and limitations, and then we kind of leave it at that, right?
So they're acting like an advisory, basically. They recommend, but typically from our organizational standpoint, we follow what the physician's concerns are and rely heavily upon them, as well as the employees' physicians on that matter. So,
Right.
I mean, obviously there's a lot of collaboration when it comes to personal care physicians and the physicians here at the University of Utah when it comes to some of those bigger issues.
Right.
Right. So it basically comes down to either you can physically do the job or you can't. Like based on your findings. Like
Right.
obviously if someone can't hear or if they're partially blind, that's going to exclude them from the profession of firefighting.
Yeah, right.
Right.
There's definitely the conditions like
One thing that is important to note is, we look at all options with the University of Utah to see how we can maybe get them off of that category A and maybe into a category B. We don't just say, it's a no-go. Sorry, try back next time, or, find a new career.
that.
We try to find all options that are available for that employee
Yeah.
to be able to work.
Yeah.
And to that, just from personal experience, I know there was a lab error on one of my things, but it kicked back. And I know that working with Cal and Greenie, both, that was the main design, is let's just get you to a point that you can go back to work. And mine turned out to be an error when I followed up with my personal physician. But I can tell you, just for the listeners, that Cal and Greenie will help you out to the extreme level that they can. And both of them are excellent to work with. So that's just a little personal plug in for those two.
Yeah. So, but yeah, so again, when we do our best. I talked with our providers. Our job is never to try to get the firefighter to not work. We always are trying to get a firefighter work, but we have to look at it as in a health and safety manner, right?
Sure.
Under the umbrella of health and safety. You guys work in a very vigorous field, obviously, and you have lots of risks, both physical, emotional, and health-wise. And one of the things we'll talk about too is the cardiovascular side of things, because I think that's one of the bigger ones that people have to deal with, because there's so many areas in the NFPA and just in the research that can cause cardiovascular concerns with firefighters. And so that's why there's additional tests that are done to make sure that we're keeping that as safe as possible. And I talk about this with any of you guys that I've done your physicals with,
Yeah.
but there's going to be certain cardiovascular risks that you can't change, right? You're
Right.
getting older, can't change that. You're a male, even if you change it surgically, you're still a male, so you can't change that. Those increase your risks.
Right.
There's genetics that, again, you can't change your genes, but we can look at cholesterol. We can look at your cardiac function and see if there's ways we can tweak those things to lower that risk. So we look at the what we call modifiable risk factors with you guys and try to tamper those down and keep those under control as much as possible so that it doesn't add to the other risks that are unchanged,
Right.
we can't modify.
I want to interject here real quick. If anybody is interested in looking at the NFPA standard, anybody can go online through nfpa.org and you can sign up for a free account with NFPA, and you can look at any standard that's out there. You have to give them your email, you have to give it a password to log on in, but then you have access to view any standard. And so, like anything out there on NFPA, you can have access to look at the standard and see what it's saying. So you actually can educate yourself a little bit as well if you have any concerns about the standard.
Sure.
So none of this is secret. It's all out there.
Oh, yeah,
Absolutely.
absolutely.
And if you're ever in a clinic and you have a concern and you want to see, we have hard copies of the NFPA in clinic. And so if you're like, well, can we look at it together and make sure that I understand why it's coming? We'll just bring it in and we'll say, here's the section we're concerned about, and this is why.
Well, and to me, what it sounds like is an organizational play of hard boundaries, soft heart. That basically sum it up pretty well.
I agree with that. You know, we want to make sure that people are healthy coming to the job because the inherent risk of the job. And then we want to create a situation in which we're setting people up for success, not for failure. And I don't think we'd be very good to our employees, and especially not the families of those employees, if we put our head in the sand and look the other way when there's pressing medical concerns.
That's part of soft heart.
Yeah.
I mean,
Right.
want the best for each of us. So
Yeah.
right on.
All right, go ahead, Doc. Sorry.
No, you're good. So that's kind of the 1582. And again, just to clarify, so it does break it down between members and candidates, right? So there is sometimes there is a differentiation. So if you're wondering why sometimes there's a little bit of differentiation, because that's the 1582 standard actually has that.
Yeah,
Okay.
in the candidate aspect, it's a much broader. It's a little higher hurdle, in my opinion.
It is.
And when you say
clear.
candidates, you're talking about new recruits.
New
Right.
recruits,
Okay,
yeah.
got it.
New employees coming on into the job.
Right
Yeah.
on.
And so what you're looking for in a new recruit is maybe a healthier standard
It is because
than what our current employees are at.
Yeah, because they haven't shown. This is how I take it. I didn't create the 1582. I don't know all the politics and the things
Right.
behind it. But I look at it as they haven't proven that they can do the job with whatever condition you're concerned with.
Right.
So it's a little more rigorous because you guys that have already been doing it, it's like, well, I have this, but I've had it for 10 years and I'm fine. That
Yeah.
allows a little bit more leeway to get somebody cleared.
Right.
So I think that's how I look at it anyway.
Yeah.
Yeah.
Absolutely.
So again, another part of the 1582, it actually says, okay, here's the components of the examination that we want you to do, right? So the medical history, which vital signs you need to make sure to get done, the audiogram testing, the spirometry, all that stuff, what we do on physical exam, all that's kind of spelled out in the 1582. So we follow that. Of course, we sometimes will do a little bit more just to make sure, and we can adapt it, of course, clinically. If we're in there and somebody's having trouble with something or there's some concern on the history, or we may add a little bit. But most of the time, most of your guys' exams are going to be pretty much the same for everybody who comes in. Then you have things like chest x-rays every 5 years, the TB testing, all that kind of stuff, the echocardiograms if you need them, ECGs, all that stuff is dictated by the 1582. So we already talked about those. So why don't we go ahead and start and jump into the stress tests, cardiac stress tests.
Be good.
Because I do know that that's one that not just Unified Fire, but everybody's like, well, why do I have to do a stress test when if you were not a firefighter, granted, we probably wouldn't necessarily have to do as many stress tests under the same clinical findings. So if you have
If you're like working in petrochemical industry,
right, petrochemical industry or something, you may not have to do as many stress tests. So to answer why, so just to clarify, one, we don't make money off of your guys' stress tests, right?
Right.
We've actually negotiated a deal where the university loses money for every stress test we do for firefighters.
That's really poor negotiation.
I know.
man.
It's because Mike Greensides is really mean when he negotiates.
Yeah.
So, but it's just in case. I don't know if that's their perception, but obviously there's no like brownie points that come to us for ordering them.
There's
And
no
like I said,
kickback or
there's
anything
no
else.
kickback or anything.
Okay.
And like I said, the university, we charge just for the cardiologist's time, but not for the equipment or the technologist or the building. I mean, that's all written off. So they're losing money. That's why you won't find a stress test with imaging anywhere close to the price that the firefighters pay.
And we're paying that as a department
You
to
are.
clarify that too,
Oh, okay.
which is also sometimes maybe different than other jurisdictions, but we actually cover that cost currently.
It is different. I can say that for sure. So to go over some examples, metabolic syndrome. So metabolic syndrome is kind of like a best way to think of like pre-diabetes possibly.
Yeah.
So it takes into consideration abdominal obesity, so like circumference and things, your triglyceride levels, your HDL levels, your blood pressure, and your fasting blood sugar. So if three, usually you have to find out of those five, 3 of them that are technically abnormal in a certain way, then you'd be diagnosed with metabolic syndrome. And according to NFPA, if you're diagnosed with metabolic syndrome, you need to have at least one cardiac stress test with imaging. And again, that's looking to just make sure. So the stress tests, and it's probably pretty self-explanatory, but you're doing it, we're putting your heart under a little bit more stress than lying down on the table and doing an ECG,
Right.
You're actually getting up to what they say is 12 METs or metabolic equivalents, which isn't horrible, but it's not just walking either. 12 METs is a pretty good pace.
And that 12 METs is actually also an NFPA recommendation as well.
Yeah. I mean, they say you have to reach 12 METs.
So you're running on the treadmill, you're hitting 12 METs.
Yes.
And what does that show?
So, well, one, we have to make sure you can hit 12 METs and not stop or have any
That
problems.
would be awkward.
Right. So that's the first thing. Secondly, we're looking at the tracings. So we're making sure there's because sometimes if you're at rest, if there's a little bit of damage or a little bit of blockage somewhere in the heart, you may not catch it.
There's no irritability of the conduction
but,
system.
Yeah, it's going fine. But once you kind of stress it out a little bit, make it work a little harder, you might notice something that otherwise is normal at rest. So that's the idea of a stress test, especially for you guys. And then we do the imaging where they actually look at the heart, making sure that the valves are doing well, and the wall motion is normal, and the flow and the contractions and all that stuff. So you guys get stress imaging, cardiac stress imaging. So not just the stress test, but you do get the imaging as well. So that's the idea of the stress test. And again, we're just making sure that if there's any modifiable risk factor that we can identify during that, then that's what we need to do. Whether it's going to be a medication, whether it's a lifestyle change to start off with, anything along those lines that show that we can prevent a cardiovascular event. Okay. So metabolic syndrome, and NFPA says if you have metabolic syndrome, you need to at least do one stress test with imaging.
Is that because metabolic syndrome increases the load on the heart?
It does. Well, yeah. So it increases the cardiovascular risk for all those reasons. So obesity does.
Right.
So don't totally quote me on this because I haven't looked at it for a while, but like for every pound of fat our body creates, it has to create quite a few blood vessels to feed it. Fat really likes blood.
Yeah.
A lot.
Yeah.
So it not only creates more blood vessels, it also releases some hormones, the fat cells do, to keep the blood pressure elevated. Because again, it wants to make sure it has plenty of nutrition. And so your heart is going to have to work harder with more, adipose tissue. It's just the way that it is.
Yeah.
So, and then of course, the cholesterol, the triglycerides and things, those are things that kind of can cause plaques and such. So we want to try to identify those.
Okay.
And you do that with a stress test. And same thing with the fasting blood sugar.
So is metabolic syndrome the same as prediabetes?
Technically not.
Okay.
Because prediabetes is just kind of like a general term that doesn't have exact diagnostic criteria, but metabolic syndrome does.
Okay.
But usually, if you're saying prediabetes, you're often
it'd be in the same boat, basically.
Kind of in the same boat. But again, the metabolic syndrome, you have to have 3 of those 5, and fasting blood sugar is only 1.
Okay. All right.
So
perfect.
Yeah.
Thanks.
Yep. And then, so high blood pressure. So hypertension, there's different stages, right? 1, 2, and 3. And then, so there's kind of normal blood pressure, hypertension stage 1, hypertension stage 2, and stage 3. So NFPA says if you've been diagnosed with stage 1, you need to make sure you go get treated for it and get screened for end organ damage. So end organ damage would mainly be your eyes and your kidneys for the most part, or the heart itself.
So what parameter would be stage 1? Like at what level?
Right. So stage 1 right now, well, it depends. So they just changed this, but according to NFPA, it would be the systolic would be 120 to 140 and diastolic would be 80 to 90.
Okay.
If you fall in those range, either one, doesn't have to be both. Either one, you would be diagnosed with stage 1 hypertension.
But didn't the American Heart just adjust that?
They did. They made it lower. They made it more strict.
Like 110.
I want to say, I think it's 110, and I think it's I think it's 8, like 70 to 80 is
okay,
so forth. So we have to look that up. But it's more stringent than the 1582 currently has.
Okay.
Well, this is a good time to interject here. A lot of times, because based upon studies and changes in academia, obviously the NFPA sometimes a little delayed in making these
Sure.
changes.
Sure.
And so, it's a kind of a circular event, basically.
Right. Because, I mean, they just came up with the new one, right, in 2018, but that was decided upon a couple of years ago, probably,
Right.
Yep.
right? Created and decided upon and finally came out in 2018. This new recommendation came out the end of 2017, I believe. And so I believe, the NFPA for 2018
It's
was
not a
already,
revision.
Yeah. So the next one may come out and be a little bit different. But right now, we're going with the older stage 1, stage 2 hypertension. And it says, so if you have evidence of end organ damage, like I said, usually you'll see that in the eyes because you can actually see the blood vessels in the eyes.
Yeah.
Right. When you do it, especially when you do a dilated exam. And then the kidney, so your kidney function, because the kidneys are filtering all the blood.
Right.
So stuff that affects blood, blood pressure affects the kidneys quite a bit. So if you have that, or if you have a 10-year risk score for the American Heart Association of 10% or greater.
Yeah.
So stage 1, end organ damage and or at 10% or greater, then you have to get a stress test.
So just a question on your end. This is something that is relatively new in terms of what we're doing in departmentally, in terms of people getting notified and going through this process. Why now? Was there a change?
Well, we have been doing actually stress tests for now, 2 years, a year and a
At least, I would say even longer.
Yeah, at least 2 years. But we've been doing stress tests for a while now, and actually providing that as an incentive for the employee to ease that burden of cost on the family and other out of pocket cost. The changes have happened because now there's more using these scales and these criteria. I think that's some of the new changes that have happened recently. Is that right, Doc?
Yeah. So they're recommending it more often.
Okay.
So before we were really doing it if there was an abnormal EKG or ECG, a new finding, right? Especially if we could say, well, this is different, this is new. We're going to stress and make sure that there's not any ischemia, that we're just not catching on this.
Okay.
And or diabetes was another one. So if you're a diabetic, there were certain, you always had to at least get one, and then every 3 to 5 years, you'd have to get another one and so forth. So that was what we were doing before. We've added additional stress tests based off of the newer recommendations. So it's happening a little more often than it has in the past few years.
Yeah, and dating back a couple years ago is when UFA started paying for the stress test as well. So before, and correct me if I'm wrong, doctor, we used to let them go through their own insurance providers and their own doctors and then bring the results back, which of course increased a little bit of time and cost and burden to the employee. So it was about 2 years ago.
It's at least
2 years ago
as well.
So obviously, to help the employee, we view the physical as a huge benefit for our employees, and we want to keep it that way and not be a burden. So when that does happen, that is why we pick up the cost.
Awesome.
Yep. So hypertension, both stage 1 and stage 2.
So it can be looked at that the stress test is a preventative measure. This
Absolutely.
isn't a punitive measure.
Yeah, no.
It's a preventative
Absolutely.
measure. And just, hey, you might wanna.
Yeah.
And again, it's for those modifiable, but I could be wrong, but I don't think we've ever done a stress test and then said somebody couldn't work. Sometimes we've done a stress test and said you need to do these things to help you to be safe while you're working, because now we have a better idea of what's going on. But it's not like we're doing stress tests and then failing people for work.
I'm not aware of any case like that.
Yeah, we've had individuals more on our part-time, when it was the paid call system, that weren't able to work with UFA because of factors that happened, or health factors or health risks they had. But yeah, I'm not aware of anything besides that as well.
And it's also to put in perspective here. Since the first of the year, we've had 6 people referred out for stress tests. So it's not happening all the time, but it is happening consistent.
Yeah.
So
Preventative, not punitive.
Yeah.
Preventative.
But it's good that our department's taking a proactive approach in investing in preventative healthcare.
It is.
I'd rather
employees.
know. I'd rather know if I
Yeah.
had something going on.
I'd rather
or not.
know I was about to have a heart attack than actually have a heart attack.
Right.
Right.
And there's still a risk of, the person having, a cardiac syndrome of some kind, even after the stress test. But we're just trying to minimize and close that window and make sure the employee has every opportunity to get on a healthy path if they're not already there.
Yeah.
Cool.
Yeah.
Awesome.
Yeah. No, like I said, Unified is great. I did a pre-hire physical for a different so far this morning, and
Yeah.
he's a diabetic, so he has to get a stress test, but he has to pay for it himself.
Oh,
So I mean,
man.
he's going to do it, and it'll be fine, right? Because that's what he
Right.
needs to do for a pre-hire. But the department's like, no, he needs to figure out how to pay for that on his own.
Right.
But they still have to do it.
Yep.
Whether it doesn't matter who pays, it still has to be done.
Right.
Sounds expensive.
It can be, like I said, though, we got you a pretty cheap deal.
I'm just saying, like an out-of-pocket
Oh,
expense. If
it
I was
is.
like, if I was a new hire,
Oh yeah,
like
you're just
going to see a cardiologist and get a stress test, that sounds pricey.
Well, think
Well,
about
let's-
that too. If you're coming in a new hire, you may or may not have insurance too at that point.
Right.
right.
And so, I mean, you're literally that's a lot of money
Yeah.
and a
It is.
very bad
Yeah.
time when you're looking at buying uniforms and being away from a new job and having that break in your employment. So,
right.
PS stress test.
yeah.
Exactly. So, and in conjunction with stress tests and other things, there's going to be conditions where there's going to need to be some additional tests done. And that's when you're going to be referred to your private physician for either just your own health. So there's lots of things that we check and we see that we're not going to say you can't do your job because of it. But for your personal health information, for instance, you should get this followed up. This should be something that's not going to limit you from your job.
Right.
But I wouldn't ignore this either.
Yeah.
So you're going to get recommendations a lot of times with laboratory results to follow up with your private health provider.
Yep.
And most of the time we don't ask for anything back on those. Only if it's kind of, whether or not we can get you fit for duty, then we'll ask for some information back from the provider. Otherwise, it's between you and your provider.
I think that's a perfect segue. If you could just talk about it a little bit. Sometimes when we have the physicals, we'll get letters saying that they're either pending or they're passed. Can you just talk about that a little bit when they're
Sure.
pending, why they are pending, and what we are waiting for?
Yeah. So if we actually need some information back, either we need to redo the ECG. Let's say you come in, it's abnormal. Sometimes it just depends on the electricity of the day. I mean, sometimes you'll get one and it's abnormal. You do it again 2 days later and it's normal, right? So sometimes there's going to be something as simple as we just needed to come back and test something different, or the urine was a little off. I'm just going to have you come back.
Tasted weird.
Yeah, exactly. I'm going to have you come back in a couple of weeks, redo it. So we'll to let Unified know that you showed up for your appointment and things, we'll go ahead and still send them a letter saying they came on this day, but there's some stuff that's pending.
It's also important here to also to make everybody aware, we do not have access to your medical file.
Nope.
We do not know of the situation in which further follow-up testing is done unless it's a stress test, and it's merely just, hey, this person needs a stress test. There's no factors like this is a reason why this person needs a stress test. It's just this person's been referred out for a stress
I'm really
test.
glad that you brought that up
Yep.
because I've heard that several times. Well, they're looking at everything that comes
No,
back.
literally, we get a one-page letter. It says either we need follow-up or whatever else, or it says they're released and found to be fit for duty.
Yep.
Right. And you guys can, through the MyChart system, which we can talk about, you can see the letter.
Right.
It's not like we're not hiding the letter
Yeah.
from anybody, right? So it's in there. It's in your chart. You can log into MyChart
Mhm.
and say, look at my letters, and you can see exactly what
Yeah.
is written to Unified.
Yeah.
And I think that's a plus, with our organization, having this this other third party involved is protecting the employee's personal health information and looking at it from a third party standpoint and from the NFPA objectively. And so it's not an employee of Unified Fire Authority, not placed in that situation. The records aren't stored on site. Another plus, I think,
Yeah.
having a system like this.
Yeah.
So Captain Greensides, you're not sitting in your office reading through medical charts,
No, not
deciding who can
no.
come to work and who can't.
And
Okay.
honestly, when employees have given me a call and they talk, obviously there's a little angst in their voice as they receive that they have to do some further follow-up. They'll ask me about the situation and they say, well, you got to know. And I don't know. I have no idea
No.
what you're talking about.
He doesn't.
So
Yeah, he'll just know if it's been pended.
Okay.
If it's not
I
pended.
think employees just need to realize that just because it's pended does not mean that you can't go to work
No.
or that you're taken off of shift or duty. They're just pending more information that is needed. So I think that's a lot of the confusion sometimes. I get the phone call and say, my physical's pending. I
What does
can't
that mean?
work.
Right.
What do I do? So it's not.
Can I
it's
go
not
on
that.
admin?
Yeah, no, if there ever is a condition where we say it's not safe to work,
Right.
that's a phone call to
Yes.
Cal and Captain Greensides. That's not just a letter saying, hey, by the way, 'cause you never know when that's going to be done. So if that ever happens, that's not a simple letter. So if you ever see a letter that says pending, it just means we need you'll know,
Yeah.
the firefighter will know what information we need, and we're waiting for that information. Still cleared for duty. There's nothing that in that scenario that we would have to say, yep, you can't work.
But we also want people, if there's those pending tests that need to be done, is to be diligent in setting those up.
Yeah.
Sometimes we have a tendency in the fire service to kind of drag our feet and wait as long as we can until the very last minute, and then it's panic mode.
Sure.
And obviously, from your side of the coin, from being a physician and then signing off on the employee to make sure that they're able to do there's probably a little bit of angst there as well. Like,
Yeah.
where's the results? Where's the follow up here?
Mm-hmm.
And then meanwhile, this person's still on
Still
the job.
on duty, right?
Yeah.
A firefighter does his best work in the 0 hour.
Well, I could
I
see
fight
that.
what you fear.
Yeah.
Yeah. So
Right. That's why I think it's the whole procrastination level.
Yeah.
yeah.
Yeah, I mean, it has been known to have somebody come back the following year and to say, you were pended last year and I still didn't receive anything on this. So yet again, we're going to be doing it this year.
So since then, we've been working with Brooke here at the University of Utah, and we have set a 60-day window that we are going to need information back. Now, that could be even as simple as my appointment isn't until this date. So we are tracking that a lot stricter than we were if things are pending
And
to try to avoid that situation. Exactly.
And 90 days, I feel like, is a generous window to follow up.
Yeah.
And so this sorry, that's a good point for us to maybe transition to. When would an employee be shifted out to their own primary care physician or to somebody else versus, having it done here? Why can't you just look at them and evaluate them in these situations and determine?
Right. So if it's something as simple as a physical finding or something, that's easy. We can do that.
Right.
If it needs additional testing that's not covered under the unified contract, then that's when it's referred to the private health insurance arena.
Can you give some examples of that? Anything off the top of your head?
So let's say they have like an abnormal, direct bilirubin or something, or normal direct but abnormal indirect or something.
That'd be liver function.
Liver function tests.
Okay.
Yeah. So if something along those lines is occurring and you need additional tests or you need to repeat the test, that's when we refer you out to your personal physician and say, look, here's what we need. We need these additional tests. These aren't covered under the unified contract. You guys can't pay for everything under the sun for their health care if it's not work related, especially. So get these tests done with your personal provider and then follow up. Now, if they're personal providers at the university, that makes it easy. I just can look it up. If it's outside, then we just wait for those results to be sent to us and released to us, and then we follow up.
Yeah, some of the ones that come to my mind is especially eye physicians.
Sure.
And follow up from their eye physician on, maybe it might be the blood vessels in the eye or whatever else,
Right.
have that.
If you need a dilated exam, right? We don't do dilated exams here.
Yeah.
And so if you need a dilated exam, then you have to go to a physician, a doctor's office or an optometrist or something that does those exams and then get us the results. So those are the kind of the typical type ones, usually laboratory type test results.
Yeah.
And
right?
there have been cases that you refer people out to their own cardiologist because of past history as well.
Right. Yeah. So if they've had other conditions, diagnoses, treatments in the past, then we just need to follow up and make sure from the treating provider that everything's being done
Okay.
for that
Yeah.
for that individual. And so they just write a quick letter. Some of the stuff I have form letters, so that's really easy for the physicians to check a few boxes and sign it, letting us know the information that we need to know. Some of it's a little more specialized. We don't have form letters, so we just have to communicate with the provider.
And, if there's any confusion, and we know we've had set up these things in the past, if there's a concern from the primary care physician's aspect and you're not getting information, you'll speak directly, a lot of times directly with the physician and try to understand or help educate them about the risk, especially involving our occupation. Is that right?
Right. That's right. Because sometimes, no fault of their own, they don't understand exactly what the firefighter duties are.
Right.
So we're asking them to clear, so to speak, on this. And I don't think it's fair to say clear them for this, but not give them an idea as to what you're being cleared for. Right.
Yep.
So we will talk to them and say, hey, these are the types of conditions they need to, you're obviously going to be working in. And it's somewhat self-explanatory that firefighters are in a hot environment at times and have to lift heavy things, but they may not really just think of all that when they're saying that they're cleared.
Yeah,
Okay.
I'll get a lot of people that call and say, I passed my annual physical with my primary care physician, and now I have to do a follow-up test with the U of U. Why is that? And I think that's exactly the point too, is the physicals aren't exactly the same when we're doing an NFPA physical versus, a regular annual
Well, they
physical
don't
as
have
well.
the NFPA
Correct.
standards sitting
Exactly.
there.
Yeah.
And there's
by that.
benefit, obviously, having an occupational medicine doc do it. There's obviously a benefit of having the NFPA as the guideline to do it.
Mm-hmm.
And unfortunately, across the country, if you look in past line of duty deaths on the NIOSH reports, there's circumstances in which employees, now deceased, went to their own physician and convinced their own physician they're able to do the job, and they got signed off.
Right.
Meanwhile, they had all these risk factors that were screaming that there's a problem, but because they didn't have an understanding of the NFPA and especially their job, they were allowed to come back to work. And I say allowed, it sounds bad, but really look at the end result.
Yeah.
And what could we have ever prevented?
Right.
Well, it's
in
like
that
Chris said a
situation?
minute ago, I would rather know I was going at risk to have a heart attack than to actually have one. And if they're not being told, particularly with the risks that are in NFPA and what it spells out, they would miss something. And again, no fault of their own,
Sure.
but they're going to miss something.
Correct.
Right.
Yeah, and I think it's also important here to be mindful of the physicians doing the physical. They're looking at you in a snapshot, right, Doc?
Right.
And so, to have obviously with our standing relationship with the University of Utah right now, it's been awesome. And I think we're starting to develop a really good rapport. A lot of times you're seeing the same physician numerous times now.
Right.
You got to have a good understanding. But you got to understand that limitation for everybody else listening to this, that it is a snapshot. You're looking at the information, and they're using their qualifications and judgment and knowledge based upon all of their history to make a judgment call on somebody's ability to continue to do the job healthy and safely.
One question I have, and it's a little bit left field, but
Weird.
right, coming from me. When we see an intern here, and I've had that,
Right.
is that intern within the specialty or are they
Yes.
general?
So we have our own residency program. So the residents that we work with are residents in occupational medicine. And I would probably say 80 to 90% of them are board certified in something else, whether it be internal medicine, surgery, emergency medicine, and then anesthesia are kind of common ones. And then they decide to do additional training. Or they're from the military and they've been in practice for 10, 20 years. But in the military, you don't have to finish a residency to get started. So you can be a flight surgeon pretty much 1 year after medical school. So they can do that for a while, and then they all want to be board certified in something, and so they come back. So some of the quote unquote interns you have been actually practicing medicine for 30 years or so, but they're coming back to residency.
Right on.
Yeah.
So can you, sorry, I know we're kind of hijacking your time here, Doc,
Sure.
but talk a little bit about the CDL requirements, especially involving sleep apnea.
Sure. So CDL it's a federal, program, federal motor vehicle.
The Department of Transportation.
Yeah, basically takes it over. So there's certain criteria that you have to follow. And sleep apnea is one of those ones that they've been addressing and changing and things over the years. So if you look it up, it's a kind of a confusing trail of requirements, recommendations, treatments, and so forth. But basically, if you have something that's suggestive of sleep apnea for a CDL, you have to get screened. And if you have it, you have to be treated and you have to be compliant with that treatment in order to get your CDL. So the large majority of people are treated with a CPAP machine, right? Those things that you put on at night and that put the pressure so that you don't have the apneic events. So you have to use those like 80% of the time.
Through a data log, show the proof.
For the data, you have to actually, bring in the log that says I've been using it this much of the time. Sometimes with you guys, I've let it go down a little bit lower because of the shift work, right? Obviously.
Yeah.
So there's a little adaptations that we can do for that. But for the most part, that's usually where the standard is. And
when is that typically indicated? If a new employee is coming in for their very first time for a CDL, and then all of a sudden they say, well, you got to have a
sleep
survey.
test. Yeah. So there's a BMI component to it. Okay. And it's not just the BMI, it's the type of BMI. I mean, you know that muscle weight versus fat weight the BMI does not differentiate there. but when you're seeing the person in clinic, so there's like a neck circumference, abdominal circumference. There's a questionnaire that you do, like how tired are you if you sit and do this and this and this, and depending on your responses, that can trigger a screening. We'll ask, do you snore really bad at night? Does your wife or your husband say that you stop breathing at night? I mean, there's not like a hard set rule that says automatically if this is positive, then you have to do the screening test. Again, that's where if you look at the trail, there are some out there. There were some BMI measurements that said you had to do it. There's some neck circumference measurements, but then they've kind of pulled those away and changed them and so forth. So it's kind of a gestalt to some degree. But basically, if you're at risk, and there's also a Mallampati score where if you look in your mouth, how open your throat is, basically. And there's different scores, and if there's a higher score and the different things, then you are more likely to have sleep apnea. So you kind of take all that together and then say you need to have a screening.
And obviously, these changes have come, unfortunately, because of some negative outcomes in the commercial driver's license side of things.
Yes.
And obviously, the Department of Transportation has tightened up the requirements.
They have.
Now, you guys have to go through a certification process as providers.
We do.
And be approved or go through a testing, actually, a CME and as well as a testing.
We have to do a training course and then pass the test.
And so, and then the different, those who may have not gone to their CDL recently, it's all electronic now.
Yep.
The card itself is no longer a paper form. It's electronic.
It is. It is all electronic, and lovely federal government. I think the site's been down for 8 months. So you can't. So there's a company called Safe Lane, and that's, some of you guys may have done that already, where you go online and answer your questions. That's the only way we can submit the information to the federal government currently, because their site, if you go directly to it, has been down, I want to say at least 8 months.
Okay.
So that's why you're doing the Safe Lane right now for sure. Because before you could do paper or Safe Lane,
right,
but paper won't get submitted. You won't, the driver's license division won't
Doesn't show anything.
Not until they fix their site. So for sleep apnea, what's interesting is NFPA for the first time in 2018 also now addresses sleep apnea, because we've kind of in the past said, well, what are the odds you're going to be on, racing to a fire with a whole bunch of guys and fall asleep at the wheel, right? I mean,
knock on wood. Now
not,
you've said it,
right?
I think it's happened. It's happened somewhere in this country.
It could. I mean, it could happen.
It has,
but probably not as much as a guy who's driving by himself for 20 hours on a dark road,
Yes,
right?
yeah.
Mhm.
So there's kind of a difference there. So in the past, we've been way more lax on firefighter drivers than we have on just regular commercial licensed drivers.
I think it's important here, though, to look at the correlation of sleep apnea, though, and cardiovascular stress as well, though.
Yeah. So it's not just the driver
Right.
safety. Right.
Sleep apnea is deadly.
It is.
People die from it
It
a
does.
lot.
They do. And
I actually had a partner that I worked with on the ambulance that died from sleep apnea.
okay. Yeah. So, I mean, you can die directly from the apnea, or like you're saying, the stress on the heart. So you think about it, you're sleeping and you stop breathing. So what does your heart do? It races. It, the adrenaline pumps. You don't have the same stage of sleep because your adrenaline's pumping, your heart is racing and stressing it out until you wake back up enough to re-engage some of those muscles, reopen the airway, and then you breathe. And then you do that for a little bit, and then your body tries to go back down into the deeper sleep, which you need.
Right.
And that happens again. So it pulls you out of that deeper sleep, puts you in a different stage sleep. So even if you're not waking all the way up, you're not getting the rest that you need. And all night long, your heart is racing constantly.
Yeah.
So yeah, you have a huge cardiovascular risk with sleep apnea.
And if that's going on every night, the chronic
Yeah.
exposure
Mm-hmm.
is what's going to cause some serious problems.
In the NFPA, they have some different scores. You talked a little bit about the 10-year risk assessment for American Heart Association.
Mm-hmm.
Can anybody log in and look at those type of things?
Yep. So if you log on and just search it, there's a calculator.
American Heart Association 10-year risk.
10-year risk. Let's see. American Heart Association 10-year cardiovascular risk calculator, I think is all. If you put that in Google, you'll come up.
And what
with
does that mean?
So basically what they're saying is it's an epidemiological kind of thing, because no one's going to have a 10% risk of a heart attack. You either have one or you don't have one, right? It's a 0 or 100% for the individual, but you're looking at a population.
Mm-hmm.
And you're taking that number and you're saying, based off of these factors, age, blood pressure, smoking, gender, cholesterol, that kind of stuff, what is the risk in the next 10 years that you're going to have some cardiovascular event? And again, it's kind of a weird epidemiological way to apply it to individuals, but they're saying, if it's less than 5, then you're really not at elevated risk. 5 to 10, you're elevated. Greater than 10, you're way more elevated to have an event sometime in the next 10 years.
Mm-hmm.
And again, it's either a 0 or 100% for the individual.
Yeah.
But
Yeah.
then based off of those scores, cardiologists take that and say, okay, based off of this score, here's the treatment we're going to do. We're going to be more robust in treating your blood pressure and your blood sugar and your cholesterol than we would be if your score was less.
Gotcha.
So that elevates your risk. It's
Okay.
kind of an estimate of risk. So, NFPA does ask us to do that now for everybody who comes through.
And if you score a certain more, does that go to a different score? The Framingham score? Or is that?
Well, Framingham is just another calculator.
Okay, so it's the same thing.
It's similar type of thing. The American Heart Association and stuff said, well, we think there's a little bit of stuff that needs to be tweaked with the Framingham score. Framingham is a big longitudinal study that started, I want to say in the 80s, but it may have been sooner than that. They've just been following people throughout their lives, not necessarily doing any interventions, right? Just having them every year get a physical and a questionnaire, what medications they're doing, and just following over time to see what happens. So people have been taking that data for decades and
Okay.
calculating risks of different things, cancer, heart disease being some of the major ones.
Okay.
So based off of that score, like I said, when we're talking about stress tests, that score factors into whether or not you need a stress test sometimes. So like with stage 1 hypertension, if your score is high, even if you're being treated, you still need to get a stress test done because your score is high enough.
So again, anybody can go on, look at it,
Yes.
themselves and see the.
And where do we
factor.
look again?
So if you it's on their sites, but if you
Just
just put it in
Go to the Google machine.
Yeah.
and
and just
Okay.
type it in, and
American Heart 10-year
American Heart
calculator.
Association, 10-year heart risk calculator, anything along those lines, any kind of combination, you'll find it.
And
It'll
it
come up.
literally is just put in numbers and you can use your My Chart figures,
Yes.
what you've got,
Right.
and you put them on in there and it
Right.
populates, and it's pretty enlightening actually.
It
Now,
can be.
now with my chart, Cal is working on something that he'll put out to the field later that will explain my chart and how to utilize it a little bit easier. But in a nutshell, is it safe to say that when we get a physical, all of that information goes to my chart? We can look at that information and get everything that we need off of it.
Right. So
Yeah.
all your test results are on there, the letters, that kind of stuff are all available. And what you should see is whatever email address you put in there, you'll get a notification that something's on your chart, whether it's a new lab, whether the doctor commented on it, anything like that. Now, it won't actually send the data to you, right? Because it's personal health information. It's protected. They can't send that to an unsecure location. So,
Okay.
but you'll say, hey, click on this link. And then the username and password that you created when you logged in, which you may have forgotten. I'm sure there's ways to get it back. But you use those, you log in, and then you'll be able to find all your labs and hopefully find
Yeah.
the comments that are on those labs.
Yeah.
Yeah. And so that, and anything else that you want on that. And that's one, it's good for your personal health stuff. Two, if you need some information, like when your last TB or last tetanus was, you can just log in and look. And if we've given it to you, it'll be on there, right? Your
Okay.
TBs obviously we've given to you, but like if the last tetanus or something along
Yeah.
those lines.
And if we have questions as to what to do, can we call you, Cal?
course.
And just
Yeah, anytime. Yep.
Is there an
Yep.
app for my chart?
Well, I know there was. I'm not sure if there still
Okay.
is.
no, you don't have to make one, Chris.
I'm not gonna make one. I was just curious.
I know there was one.
I'll look into it. I'll
Yeah.
just see.
The other thing too is when
handy.
we look at your even the EKG though, is not internally read. You actually send that out for a verification through a cardiologist. Is that correct?
We do. Yeah. So we read it with you guys in the office.
Uh-huh.
And if it's normal, that's really easy, right? Oh, this is normal.
Right.
You guys can see it's normal. We can see it's normal.
Yeah.
We still send it to cardiology, but that's really just a formality. It's when there's anything that's a little bit new or different. We'll go over it with you saying, hey, this is different. Just double checking. You haven't had chest pain. You haven't had, right? Another thing like that. Okay. We're going to have cardiology look at this and just make sure, or we may have you come back and repeat the EKG on another occasion. If there's no clinical indication as to why that's changed. Now, you can have cardiac changes without physical symptoms, right? So
Right.
you can't just dismiss it completely or anything, but we will. So cardiology overreads any abnormal or normal EKG, again, just to be thorough.
Yeah.
And then compare it, and they have the ones from before. So they can also pull up your ones from 2, 3,
See the
4 years
history.
ago. And they'll say on there, yeah, this is still there, but this has been the same for 4 years. No, no concerns kind of a thing.
Great. Well, closing here, what are, from your perspective, what are some concerns that you have seen from our employees, some concerning trends, and any suggestions on how to maybe curb some of those trends, as well as what could be helpful for us to make our experience better for you guys here?
Okay. So we'll do the latter one first, I guess. So I think, we try to get you guys in and out quickly. We realize that either you're right off shift or it's your day off or whatever. So we're trying not to keep you here for very long. So a few things, if you can fill out that questionnaire ahead of time, right? You guys have access to the questionnaire before.
We get emailed.
Yeah. So if you fill that out before you come in, that shortens it by 20, 30 minutes at times, right?
Right.
So
I'm sorry for not doing that.
I mean, it's not a big deal for us necessarily, but it does prolong your visit. You're here longer with that. So, we have you come fasting, right? Mainly for those cholesterol, kind of triglycerides, and the fasting blood sugar. But that doesn't mean don't drink, right? So that means drink a lot of water. So it's not like a total fast. It's just a don't eat fast, right?
Oh.
So it's a drink a lot of water. So it's easy for them to get your blood, because sometimes you guys will come in totally dehydrated because you fasted everything. But then it takes longer for it to get your blood, or you can't get as much, or you can't give the urine. And again, that will take a little longer. So make sure to drink a lot so you can definitely be well hydrated during your visit.
You can drink coffee prior to that, right?
You can drink black coffee.
Right. I accidentally put creamer in mine once. That got me a follow-up with my personal physician.
There you go. So
Screws up your liver enzymes. Bad. Like really bad.
So black coffee is fine. And then, and just recognize, sometimes we're going to send you to the lab first. Sometimes we're going to see you first. We're just trying to coordinate to make sure you guys are here for as little as time as possible. And then, so trends, I guess. Well, one trend that's been a little better since we've talked about it is the testosterone use. And again, we're trying to lower your cardiovascular risks.
Sorry, back up there. Can you elaborate on that a little? Like testosterone use?
So like when
people are being
supplementation-
prescribed.
Yeah, being prescribed because of low testosterone.
Right.
There are some people who legitimately need testosterone. I'm not
Right.
saying that shouldn't ever occur. But testosterone level is very subjective. There's free versus not free.
Right.
And the range of normal is quite large,
Yeah.
right? If you look at the range of normal.
Plus body fat can affect like your testosterone levels,
Sure.
right?
Yeah, because
Like you can have
fat actually-
circulating testosterone, but your
Mhm.
body's not using it because
right.
of more fat,
So
right?
putting more testosterone in there doesn't necessarily change anything. So testosterone use can cause problems. It can be beneficial if needed, but it can also cause problems. Elevates your risk of cardiovascular disease. It lowers your HDL, the good cholesterol that we want to be elevated.
Yeah.
And it can increase your red blood cell count. Typically, that's why guys are less anemic in general than females, right? Because of the testosterone.
Yeah.
But then the problem with you guys is if you're hemoconcentrated with testosterone and then you go fight a fire and you get dehydrated,
Or compounding, yeah.
you're increasing your likelihood of having problems. So, in general, just kind of really educate yourselves on do I really truly need the testosterone?
Yeah.
And if I do, what do I need to do to mitigate the risks of testosterone use? So it also increases prostate and testicular cancers, right? Testosterone does.
Which were higher.
Which you're a higher risk already because you're a firefighter.
Yeah.
So if you're going to use it, then just make sure you're doing what you need to do in order to mitigate those risks as much as possible, which would be, even if you're young, you're going to have to get prostate and testicular examinations.
Yeah.
Right. So that's a general health trend. I mean, I think in general, you guys have, again, been doing better overall, but, diet and aerobic exercise, not so much weight training and stuff.
What about CrossFit?
Well, CrossFit isn't bad in and of itself. It just depends on how intense of the CrossFit. So I think CrossFit is kind of a wide range, right? You've got the CrossFit that like I would do, which is pretty benign and normal CrossFit. And then you've got people who do crazy things on CrossFit. So I would say
Like professional CrossFit athlete level.
Yeah, just stuff that you're just like, I can't believe. I saw in recruiting people too. So I saw a couple of your recruits today with injuries. One was they were squatting, jumping, turning in the air 180 degrees, landing, squatting, jumping, turning doing those over and over again.
That's not CrossFit,
Well,
by the way.
no, I know, but I'm saying like in general,
Yeah.
you just have to be
Yeah,
smart
yeah,
about what
right.
you're doing and why you're doing it.
Yeah.
So
Right.
CrossFit in and of itself isn't bad, but think I'm doing this
doing?
CrossFit. Why am I doing it? What's the benefit of it?
Right.
Right? Is it
Right.
worth the risk of the injury that I'm occurring?
I think the
to do it?
biggest issue there is making sure people are doing it in an appropriate form,
Sure.
and they're doing it the correct form. And we typically, as firefighters, if Joe's doing 35 whatever, then we can do 50, and we're going to show him. And
Regardless of the
unfortunately,
form.
regardless of the
Are
form,
you saying
and
we're
how
competitive?
just slightly.
Yeah, just a little bit.
Slightly.
Yeah.
So when you say strength and cardiovascular, what would you recommend?
So usually what we recommend for cardiovascular is at least 300 minutes a week. And typically we'll put you at
300 minutes a week.
300 minutes a week on average. That's kind of like the, minimum of where we feel comfortable that you're getting a fairly decent amount of cardiovascular exercise.
Okay.
And typically you want to do it roughly about 80% of your maximum heart rate. Now there's some ways to formally get your maximum heart rate,
Right.
but the generic way is 220 minus your age. So if you're 40, let's make the math easy, that's 180. It's technically your maximum heart rate. Like if you were exercising above that for too long, you would kind of hit the wall,
Mhm.
right?
Right.
So then you say, I want to be about 80% on average of that. Maybe pushing up to maximum heart rate occasionally, that kind of high intensity training kind of idea,
Mhm.
but roughly around 80% of your heart rate for about 300 minutes a week.
Hmm.
Okay. The activity doesn't really truly matter unless you have a specific injury or illness that prevents you from doing something. But whether you want to run versus bike, swim versus jumping jacks, I mean, that's not really, but it doesn't really matter.
Just important to get to that heart rate.
Getting that heart rate for that period of time.
Right.
So I would say firefighters should really focus on that aspect. Like your strengthening access in general, you focus on fairly decently. I mean, I don't see a huge deficit.
Core
there.
strength,
Right.
you think better than
Well, I mean, I think, I mean, most guys are going to have a harder time in the non-vanity type muscle groups because they'll focus on the vanity type muscle groups,
Mirror
right?
well
monkey.
said.
Yeah.
Right? And not necessarily focus on the non. So for core, definitely recommend core. I mean, that's a huge deal for back pain and multiple things. I would focus on the kind of isometric core strengthening exercises. So the basics are those bridges and those planks and those types of things.
Yeah.
So for our firefighters that may need some help with that, we have some great peer fitness trainers, right?
Yeah.
Captain
Yep,
Greensides
absolutely,
that can
absolutely.
assist you and can help you out with exercises and workouts and tailor something really for what you need.
For sure. So I think in general that, and then of course we'll always hit the diet, right? And again, I know there's convenience factors, there's, just knowledge base and so forth, but that's something else that, you're not always going to be 28 and a firefighter. Sooner or later, you're going to be 38 and a firefighter and 48 and a firefighter, most likely. And the same diet that worked when you're 18 doesn't work when you're 28 and it doesn't work when you're 48.
A lot of the
Yeah.
problem too is when it comes to diet is mindset.
Sure.
Like me personally, I'm gonna go to the fire station and eat all the crap my wife won't let me eat at home. Right?
Yeah.
Yeah.
Right.
It's like a 2-day vacation. I think a lot of people look at it that way.
Yeah.
That's why we go to the station, cook these awesome meals, right?
Right.
That we would never probably prepare at home.
At home. Yeah. So, but again, you have to kind of look at it in the long run,
Yep.
right? Again, if
Right.
you're 18, I mean, you still just have a good diet, but you might as well
Right.
enjoy being 18.
Right.
But if you're 38, then you need to say, no one can eat like they're 18 when they're 38. Even if you don't physically show it, usually your cholesterol shows it,
Yeah.
blood pressure shows it. Something, there's some kind of change usually by the time.
The fun's over. It's
Yeah.
time to adult.
I
Exactly.
feel like we just read my chart.
So how's our tobacco use with the department?
Tobacco use is pretty good.
Yeah?
Yeah. I would say, I mean, I don't look at your guys' department and think, oh my gosh, there's so much tobacco use in the Unified Fire.
So we're doing all
You're
right
doing
there.
pretty well there.
What about just because a lot of people are switching from tobacco to
Vaping.
the nicotine not
Oh.
patches, but the nicotine pouches. They're
The Zen.
Zin.
Yeah, like right
Yeah.
here that I'm currently consuming as we're doing a health and safety podcast. That's
you
not
may
bad.
have, you may have noticed that on the video, because I sure did. So what?
Is nicotine inherently bad for you?
Okay, and that's one of the things
So
I
yeah,
wanted
so
to check.
nicotine is not great for you. And again, we're looking at it cardiovascularly
Yeah.
mainly. It's a vasoconstrictor.
Okay.
Okay, so it makes the blood vessels constrict,
Okay.
especially those small little ones.
Yeah.
So we need as much blood flow to all of our appendages and things that we need.
Right.
We don't want to block that off.
Okay.
So nicotine in and of itself, even if it doesn't necessarily raise cancer rates per se,
Yeah.
it does increase cardiovascular disease.
Well, and it'd be worse, particularly if you did have something like diabetes or something
Absolutely.
like that. Right. So that's,
Yeah.
Or chronic injury of any kind. Like if you're
Yeah.
trying to heal, you have chronic
Yeah.
back pain, chronic knee pain, you need blood flow.
How does nicotine compare to caffeine?
So nicotine is a greater vasoconstrictor than caffeine.
Okay.
For
So it's
sure.
more potent.
It is.
Because I've heard people say, well,
Well,
I'm guilty
caffeine-
of it too. Nicotine's same level as caffeine. Everyone's got their thing, right? Like,
Right. So no, nicotine has been shown to be more of a vasoconstrictor.
Okay.
Caffeine is too,
Yeah.
but it's a shorter lived one, I think, and stuff. And so nicotine is definitely something that we don't recommend in any form.
Right.
Some forms are better than others, right? If you're
Yeah.
gonna,
Yeah.
look at the devices, you're gonna have different levels.
Yeah.
Chris, I bring it up because I love.
I know.
Okay?
I know. Well, and it's, most people I know, including myself, that enjoy nicotine have to have a constant flow into their bloodstream at all hours while they're awake. Some people, even when they sleep, just saying.
Yeah.
I know some people who chew in their sleep.
So it's got to be dangerous in and of itself, for choking hazard
Yeah.
alone. But yeah, so definitely nicotine use in general, we definitely discourage in anybody, but especially in firefighters.
But that if a person wants to quit smoking, and they bring something to you, hey, I would like to quit smoking, or I'd like to get on a better plan
Right.
as far as my diet. Do you have resources that you can give them to
Yeah.
help with those things?
Yeah,
And
for
we
sure.
have them through our primary, our
Or EAP as well.
well, not only that, but our insurance provider as well through Select Health as well.
Yeah.
There's a lot of resources, and I can help with that as well.
Cool.
Or you can go right onto their website.
But we're happy to talk to anybody about that as well and
Fair
get
enough.
resources.
All right.
Well,
Let's
I
wrap this up.
Yeah, I really appreciate Dr. Biggs being here, and we're approaching into his patient time right now. So we really appreciate your time and the resources that you provide to us as employees.
Of course.
Yeah, you and
It's our pleasure.
and your staff. We really appreciate you
You
and your
do
staff.
have an awesome staff.
We
yeah.
do.
Yeah.
Absolutely.
Yeah. No, we love working with you guys, and we'll just keep doing it.
Once
Thanks.
again, thanks for taking the time out of
Sure.
your day to meet with us. We
Absolutely.
really appreciate it.
Yeah. My pleasure.
Thank you.
Okay.
Mhm.